Okay, we're going to continue with our lecture series here. This topic is fluid electrolytes and acid-base metabolism. So, quick review. This just shows the water distribution in the human body. Males have a little bit more water than females do. Just remember from medical school, the fluid compartments are the intracellular and the extracellular. Most of our body water can be found in the intracellular compartment, whereas about a third of it's in the extracellular fluid. Within the extracellular fluid, we have plasma and interstitial fluid. And interstitial fluid makes up 3/4 of the extracellular fluid. And so we only really have 25% of all of the fluid in the body that we can manipulate as physicians. And so many times when we're manipulating the fluid in the body, we have to wait on mechanisms that allow the water to move from one compartment to the next. Secretions here. This is just a nice little chart that I put together many years ago that talked to you about what is found in the various secretions from various parts of the body. A lot of times you get a question that gives you a secretion or maybe gives you an injury or something like that. And the question will query your ability to figure out which of the electrolytes might you expect a significant disturbance in. If you have a patient who has like a gastric fistula, something like that, then you want to think about that patient having problems with potassium because there's obviously a lot of potassium in gastric secretions. Pancreas is another one too, where you can get into issues with pH and stuff like that. It's really just a reference chart for kind of putting in your brain which where electrolytes, their predominant issues are with certain secretions. When we're talking about fluids electrolytes, we have to kind of refresh ourselves on what osmolality is. And so we know that that's a measure of the solute in water. And the way we calculate osmolality is with this formula here. It's twice the sodium plus glucose and BUN. In your average patient who doesn't have issues with diabetes or renal failure, etc., then your osmolality should be essentially twice your sodium. And that's a good estimate of it. So now we're going to talk about electrolyte disturbances. And I'll be honest with you, this is a very medicine-y lecture as opposed to surgery. But that's a lot of what critical care is, even though we're doing surgical critical care. We're going to go through the electrolyte disturbances with the focus being on trying to narrow down the diagnoses based on studies that we do to figure out where the electrolyte disturbance is coming from. So each one of these may have an algorithm associated with it or something like that helps us narrow down the presentation of an electrolyte disturbance to a specific entity or at least group of entities so we can start looking closer. So we're going to start with sodium first. And the first thing you have to ask yourself about any electrolyte disturbances is it real? You can recheck the labs and things like that, but there are things outside just rechecking the labs that you have to consider that may cause an electrolyte disturbance to not be a true electrolyte disturbance. And so, for example, with sodium, we call that pseudohyponatremia. And these three entities, lipids, proteins, and glucose, abnormalities in those based on these correction factors can cause your sodium to be low when it really isn't low, or make it look low. Not that you have to memorize these correction factors. I don't recommend doing it. What I would recommend doing is knowing that, excessive amounts of lipids, proteins, or glucose can cause you to have a hyponatremia that may not be a true hyponatremia. But outside of that, if we do diagnose a true hyponatremia, then we got to figure out where it's coming from, or at least I say get a handful of entities narrowed down to say, hey, it could be any one of these things. Let's look closer. So the first question we ask ourselves in this hyponatremia algorithm is the patient euvolemic, hypovolemic, or hypervolemic? So what's their volume status, their fluid status? And if we ascertain that the patient, clinically is probably hypovolemic, then the next thing we have to ask ourselves is, bottom line is the kidney functioning the way it's meant to function in this setting, or is it not? And we do that by drawing a urine sodium, or calculating or measuring urine sodium over, after a urine collection for 24 hours. And so let's look at this slide here. If the urine sodium is less than 20, then we say that the cause is most likely extrarenal. And we do that because in a patient who's experiencing hyponatremia and hypovolemia, if the kidney is functioning correctly, then it should be retaining as much sodium as possible. And we're going to do another lecture here next that has to do with renal physiology, and we'll explain that in more detail. But the bottom line is that sodium is a driver of volume status, and the kidney regulates that. And in a patient who is hypovolemic and or hyponatremic, the kidney's function should be to retain sodium. So we would expect very little sodium to get into the urine. And so, like I said, the question with hyponatremia is the kidney doing its job, or is there something preventing the kidney from doing its job? If it's doing its job, urine sodium less than 20, then we can look for extrarenal causes of the hypovolemic hyponatremia, like vomiting, diarrhea, GI fistulas. And the other things you see with those, like the metabolic acidosis, alkalosis, those are other things that you would look for that help you narrow down the cause of this. On the other hand, if the kidney is not doing its job, you would see the urine sodium higher than 20. So it's not retaining sodium, it's dumping sodium into the urine. And so something is wrong with the kidney, or we are doing something that's to the kidney, preventing it from functioning normally. You might see that with diuretic use, hypoaldosteronism. So the treatment for this patient would be resuscitation first with isotonic saline, and then to help solve the volume status and the hyponatremia. Obviously, if the patient's extremely hyperchloremic for some reason, you can use sodium acetate for that resuscitation. So the next entity would be hyponatremia in a euvolemic patient. So we don't necessarily have the volume status, say, driving the sodium, but we do still have hyponatremia. So we would expect the same thing. If the kidney's functioning well, we could look at urine osmolality or urine sodium and expect those to be low. And we would expect that in a patient who, let's say, has polydipsia. We would expect their urine sodium to be low because the kidney's trying to retain sodium because they're hyponatremic, not necessarily because they're euvolemic. Urine osmolality would be low because they're hyponatremic. But you also might find hypokalemia with this and a history of polydipsia. On the other hand, if the kidney is the cause itself because something is interfering in its normal behavior, then we would expect and see the urine sodium to be high because it's not able to retain sodium to correct the hyponatremia. And we might say those in other disorders like SIADH or hypothyroidism, and we can look specifically at other things like the potassium behavior or those specific hormones. So if you haven't figured it out by now, it's really straightforward in working up hyponatremia. Either the kidney's doing its job or it's not. And if the kidney's doing its job, urine sodium is going to be low. You look down that pathway of things outside the kidney as a cause. If the kidney's not doing its job, it's usually due to a drug or a steroid or something like that that's causing the kidney to not behave appropriately. Last one's hyponatremia in a hypervolemic patient. Again, either inside the kidney or outside the kidney. This patient we tend to see commonly in heart failure patients or cirrhotic patients. These patients behave this way. They're hyponatremic, but they retain a lot of fluid because of their other entities, like their cirrhosis or something like that. So they're hypervolemic. Their urine sodium tends to be low, and then we have to essentially provide water and a salt restriction in this patient, even though they're hyponatremic. So this is sort of the summary of hyponatremia. I've kind of said this multiple times. Assess the volume status of the patient, then take a look at the urine sodium, and then you can start trying to narrow down what specific entity might be causing the hyponatremia. Okay, that's hyponatremia. Let's look at hypernatremia. Again, we ask ourselves a similar question. Are they hypovolemic, euvolemic, or hypernatremic? If they're hypovolemic and the kidney is doing its job, then we're going to expect to see this patient have a low urine sodium, even with hypernatremia. Remember, in the kidney, the first driving mechanism is the volume status of the patient, followed by the sodium. So if the sodium is high, but the volume status is poor, that's going to drive the kidney to retain sodium because water follows sodium. And so that would give you a low urine sodium, and those entities like GI losses, vomiting, diarrhea, use of lactulose, something like that. On the other hand, if the kidney cannot retain sodium, then there's something intrinsic to the kidney that's causing that problem, like hyperglycemia, the use of mannitol, high protein feedings, renal losses of sodium are preventing it from being reabsorbed and water to follow. Treatment is resuscitation of the patient first, and then water to correct the hypernatremia. In the euvolemic patient, again, urine sodium is low. Examples, you see this in hypodipsia or sweating patients. On the other hand, if the patient's euvolemic and they're hypernatremic, we can think about diabetes insipidus. And the urine sodium would most likely be the opposite. And then we could do further testing for diabetes insipidus by giving a vasopressin stimulation test. Treatment is water. Finally, hypernatremia in a hypovolemic patient. This is a very rare entity, honestly. It's not common. Typically, the only way to get this is by ingesting quite a bit of salt water or seawater. Treatment overall would just be to correct the hypernatremia with water. So how about all these corrections, these treatment issues we've talked about? Well, in hyponatremia, we like to calculate a sodium deficit, and in hypernatremia, we like to calculate a water deficit. And so in the end, it just comes down to treating these deficits appropriately. So here's the common rules that we try to follow. One, we don't like to correct these by more than about 0.5 to 1 milliequivalent per liter, whether it's hypernatremia or hyponatremia, per hour. This is a correction that we try to do over 24, 48 hours. It's not something we try to do immediately or rapidly. You know, you can use, one thing I point out is you can use hypertonic saline in this correction for those who are symptomatic, for symptomatic hyponatremia. But the underlying thing is to calculate your sodium deficit, your water deficit, and to provide that missing item at a rate of about 0.5 to 1 milliequivalent per hour, per liter per hour, and expect to do this over 24 or 48 hours, not more. Okay, that's hyponatremia. Let's move on to hyperkalemia. So hyponatremia and hypernatremia are the more extensive of the electrolyte disorders that you really have to look at volume status. Hyperkalemia and hypokalemia, not so much, a little bit simpler here. 3 sources of hypokalemia: excessive intake from potassium supplements, large amount of blood transfusions, or cellular shifts. We know that potassium moves between the cells, and so significant shifts of potassium can cause hyperkalemia. And then, of course, in that patient with decreased renal excretion of potassium, whether it's due to acute renal failure or medications or whatever, or disease processes, we can see that in hypernatremia. So this slide here it's an estimate. It's not if you're greater than 7, you're going to see widened QRS every time, and you have to give glucose, insulin, albuterol, bicarb. This is a slide with just some general guidance on it. The bottom line is that sort of the first treatment of hyperkalemia is to avoid potassium, those things that make potassium hang around in the bloodstream. NSAIDs restrict potassium intake. As the potassium goes up, and we want to start treating it, typically around 6, then we can do that with, this is KX-APO. This is an old slide. There are other potassium binders out there that are even more efficient nowadays. But KX-8 is still available. And then we can do sort of the temporary treatment with the glucose insulin, shifting the location of the potassium to be intracellular, and then bicarb, etc., can be used if the patient starts becoming acidotic. Higher potassiums, we give the calcium once we start seeing EKG changes, because we want to have that there to stabilize the myocardium. And then dialysis being the ultimate treatment of it. All right, hypokalemia, just the opposite. Same similar causes. We can see GI losses of this through diarrhea or fistulas. We can have cellular shifts, extra to intracellular shift, where all the potassium move intracellular. And then renal losses can cause hypokalemia, like in hyperaldosteronism, use of diuretics, etc. How do we treat it? Straightforward. We provide potassium replacement. Now, remember, even hypokalemia can cause cardiac issues. You get a flattening of the T waves instead of a peak T wave like you see in hyperkalemia. What we provide is potassium replacement, as aggressive as we can. All right, let's see. A 32-year-old sustains closed head injury in a motor vehicle accident. She remains intubated with a GCS of 5. On hospital day 4, her morning labs are normal, except her sodium has risen to 165. What is her free water deficit? Go back to your formula and calculate that out here. All right. We have a few choices here, and correct. A is correct, 7.5. All right. Let's move to calcium. Calcium is a parathyroid hormone, is the regulator of calcium. So let's talk about how that works, remind ourselves of that. 3 actions that come with parathyroid hormone. Works on the bone, the kidneys, and it stimulates the production of calcitriol. Now, what causes parathyroid hormone to be secreted? Low calcium. That's the sole thing that causes the parathyroid hormone to be secreted, low calcium. What causes it to stop secretion or suppresses its secretion? High calcium and low magnesium. Okay, so 2 things can cause it to stop secreting. Where do we get calcium from? 3 sources: our diet, the GI tract, basically, our bone, and the kidney controls the reabsorption of calcium. So in our diet, we have sort of a cofactor here in vitamin D, controlling the absorption of calcium from our GI tract. In the kidney, we have 2 things that work. Both parathyroid hormone controls the reabsorption of calcium within the kidney, and then vitamin D is hydroxylated in the kidney. So if you have issues with the kidney, you're going to have calcium issues from 2 fronts. One, you're not going to make enough vitamin D that's going to work in other locations. And 2, parathyroid hormone is not going to be able to control the reabsorption. Finally, bone, both parathyroid hormone and and vitamin D work on the bone to release calcium. Now, the calcium, hypercalcemia in particular, there's also a state that we can attribute to pseudo hypercalcemia. And that is, and we're all familiar with this, that is governed by the concentration of albumin in your body. This only affects bound calcium. It does not affect ionized calcium. So you can get sort of a falsely elevated calcium in those who have excessive albumin, like people who have cancer states or something like that, who may have tumors that produce excessive proteins or something. Hypercalcemia comes from three different sources. You would expect it to come from the sources, or the etiology of hypercalcemia to come from the sources that are involved in its homeostasis. So the GI tract, the kidney, and the bones. And so disorders involving those can cause hypercalcemia, like excessive calcium absorption from the GI tract, or excessive breakdown of calcium from the bones, or excessive renal reabsorption of calcium for whatever, for drug induced or something like that. Signs and symptoms are stones, bones, groans, and psychogenic overtones. That's the mnemonic for this. Okay, so you can get abdominal pain and constipation. You can get shortened QT waves on an EKG. You can get weakness, lethargy, etc. from a neurologic standpoint. How do we treat it? Typically, we start with hydration and a Lasix diuresis and restricting calcium. Those are the first three things you need to know. Hydration, avoiding calcium, and Lasix diuresis. Now, if this moves on to be a more significant hypercalcemia, we may need to bring in some of these other drugs like mithromycin or something like midodrine, or go to dialysis. Hypocalcemia, on the other hand, has some of the same etiologies. It can come from the GI tract, the bones, the kidneys. Signs and symptoms are very similar to what you would expect, what we check for after parathyroid surgery, right? So if you, because it's the same as in hypoparathyroidism, so you get this perioral paresthesias, chivoxoxide, prolonged QT. Treatment is just providing calcium replacement. Let's back up for 1 second. Remember, I said that suppression of PTH, hypoparathyroidism, suppression of PTH can be caused by excessive calcium or low magnesium. So think about magnesium. So before, in this patient who's presenting signs of hypocalcemia, you want to make sure the magnesium is corrected first before you start adding in calcium, because you can add in all the calcium you want. You won't correct the hypocalcemia completely without making sure the magnesium is good. Which of the following is associated with hyperkalemia? Hypokalemia, I'm sorry. Which of the following is associated with hypokalemia? Got a few answers here. Answer is hypomagnesemia. All right. Hyperphosphatemia. Couple etiologies here: renal insufficiency, widespread cell necrosis, like tumor necrosis. The manifestations aren't well documented, but we'll talk a little bit about what we can see. In particular for hyperphosphatemia. Treatment is a binding phosphate, if necessary, or dialysis. On the other hand, the one we really want to spend time talking about is hypophosphatemia. We don't get too excited about hyperphosphatemia. Hypophosphatemia, though, is something we get excited about. A couple etiologies here. Intracellular shifts can cause hypophosphatemia. You can have excretion of it, like in DKA, GI tract malabsorption, and then something we tend to see sometimes as surgeons is refeeding syndrome. One of the manifestations, so if you really think about hypophosphatemia, that is a low energy state because you don't have phosphate. If you don't have phosphate, you can't make ATP. And so everything served by ATP is going to be significantly affected in this. And so low cardiac output, hypophosphatemia can be, a killer to the patient. Anemia, oxyhemoglobin shifts. There's significant ATP production issues that causes problems with sodium potassium pumps. And the treatment is phosphate replacement. So we'll talk about hypophosphatemia and where it comes from a little bit more in another lecture later, I think tomorrow. Magnesium, it's primarily intracellular. You don't usually see a lot of it in the extracellular compartment. It is actively involved, and I showed you that in PTH release. So hypermagnesemia, we don't get too excited about this because people can tolerate a significant amount of magnesium in their body without these symptoms beginning to show. And so the treatment really is just volume expansion. And on a rare occasion, you might have to progress towards dialysis. On the other hand, hypomagnesemia can come through, again, GI losses, cellular uptake issues, renal losses. And the signs and symptoms are going to be very similar to hypocalcemia. Because remember, hypomagnesemic conditions suppress PTH release and cause hypocalcemia. So you're going to see some of the same identical symptoms with hypomagnesemia. So again, the treatment here is not to correct the calcium, but to correct the magnesium because it's what's low, and that's what's going to cause calcium metabolism, calcium to be low also. All right. Which of the following is not a cause of hypercalcemia, not a cause of hypercalcemia? Not a cause. All right, we got a few answers here. All good, I think. Secondary hyperparathyroidism. Okay. That's the electrolytes that we're going to talk about. And the goal here is just to have a generalized understanding of what disease entities can lead to disturbances in those electrolytes, and then how to go down a pathway of making those diagnoses and ruling out other disturbances or other causes, I'm sorry, and then providing treatment. So the next thing we're kind of finish up with is acid-base physiology. Now we know that the primary buffer system in the body is the bicarb buffer system. You see that represented by this formula. We know buffers, the goal of a buffer is to minimize pH changes in the organism. There are other buffer systems. There's an ammonia-ammonium buffer system. Organic acids have buffer systems like acetic acid, stuff like that in our body. But the primary one that really is truly going to regulate our pH is the bicarb buffer system. And it's defined by the Henderson-Hasselbalch equation. We can determine the pH in our body by this equation here when we plug in our normal bicarb and our normal CO2 concentration. That gives us a pH of 7.4, which is normal for us. There are certain compensatory mechanisms when we're looking at acid base and pH and stuff like that to see if there's an appropriate compensation done by the body for a metabolic or respiratory disorder. Probably the most common formula here that's memorized is Winter's formula, the first formula for acidosis, which says basically if you have sort of a pure acidosis here, metabolic acidosis, it is appropriately compensated if you multiply the bicarb concentration by 1.5 and 8, and that gives you your PCO2. There are other formulas too, not so important, probably as Winter's formula here used so much. So let's talk about acidoses. So when an acidosis appears in the laboratory studies, we need to take a look at its what kind of an acidosis it is, and then maybe its etiology. So what we're going to do here in the next few minutes is we're going to spend probably 80% of our time, maybe 75% of our time talking about metabolic acidosis. We're going to do a little bit of time on metabolic alkalosis, and then a smidgen of time on the respiratory disorders because they're fairly straightforward. So in looking at metabolic acidosis, the goal as the ICU doc is to try to figure out, is that an isolated metabolic acidosis, or is there also something else going on that I need to consider in terms of determining an etiology of this abnormality in their pH. So in the world of metabolic acidosis, the first thing that we calculate is the anion gap. And the anion gap is defined as positive anions minus the negative anions. And so basically it comes down to sodium minus chlorine or chloride plus bicarbonate. And these are the anions that are running around in the bloodstream, not the ones that are stuck in the red blood cells, because those don't affect your pH. So that's why you don't see potassium in this. But these three are the anions that predominantly run around in the bloodstream. Normal anion gap is anywhere from 3 to 11. I like to use the number 10 because it's easy to work with. And so that's the first thing we do. Some various etiologies that can cause an anion gap acidosis, or anything that can cause a lactic acidosis or ketoacidosis or toxins, renal failure can cause an anion gap acidosis. And so that's what we want to do, is we want to ascertain what type of acidosis or alkalosis we have. And in the setting of an acidosis, is it a pure acidosis? And then we can start trying to narrow down the actual etiology once we know sort of the acid-base picture. Okay, what about a non-anion gap acidosis? Well, if we calculate the anion gap, and it's between 3 and 11, it's 6 or 7. Well, non-anion gap acidoses have different types of etiologies, okay? And what you have to understand is the way you get a non-anion gap acidosis has to purely deal with what is happening to bicarb, because the body is going to make our pH normal. It's going to do three things. The body will always make glucose. It's going to make our pH normal with these buffer systems, and it's going to make us electrically neutral. So we don't run around with extra positive charges or extra negative charges in our bodies. And so that's the driver behind a non-anion gap acidosis, is to be electrically neutral. Because when you look at the ions involved in this, you got sodium, chloride, and bicarb. We only have one positive ion involved in this acidotic state. Whereas on the negative side, or the anion side, you have chloride and bicarb. And so those regulate each other from an electrically neutral situation. Meaning, if you lose bicarb, that means not only are you losing bicarb, but you're losing negative charges. So chloride will rise. And so when this starts happening, you can see that there's potentially going to be a balance or imbalance in your anion gap. Okay. Specific etiologies that result in a non-anion gap acidosis are the GI loss of bicarbonate, for example, through diarrhea, fistulae, something like that, or renal losses. So bicarbonate is the driving factor for a non-anion gap acidosis. And the reason, like I said, you get this is because let's say you have someone who has excess chloride in the body. So if you have a lot of excess chloride, then that would give you an anion gap in your calculations. If your sodium is 140 and your bicarb's 24 and your chloride is 115, then you're going to have anion gap acidosis. Or an anion gap acidosis. But if the mechanism is working correctly and the bicarb actually goes down as the chloride goes up because of electrical charge compensation or balancing, then it results in a non-anion gap acidosis. And these are the things that allow for that. GI loss of bicarb. But what happens when you have GI losses of bicarb? Body retains sodium. What comes along with sodium? Water and chloride. So that balances out the negative charge. And so it looks like it presents as a non-anion gap acidosis. Okay, so back up here for a second. We have anion gap, okay? And we calculate the anion gap. And if it's abnormal, we call that an anion gap acidosis. If it's normal, we call that a non-anion gap acidosis. Now, within these acidoses, you can have mixed metabolic pictures. And that's where the delta gap comes. Some people call it the gap, okay? And the way, and this is where it gets a little confusing here, so listen closely. This will identify mixed metabolic abnormalities, i.e. anion gap acidosis plus non-anion gap acidosis, or anion gap acidosis plus metabolic alkalosis, okay? And so the delta gap is the difference in the anion gap from normal. So let's say you calculate the anion gap. And for a certain patient, it is 35. Let's make it easy, 30. Say for a certain patient, you calculate their anion gap, they got a high anion gap, 30, and you go, okay, this is an anion gap acidosis. But you need to look further because it may be a mixed metabolic acidosis. You could have an underlying anion gap acidosis plus a non-anion gap, or an underlying anion gap acidosis and a metabolic alkalosis. And the delta gap helps us tease this out. So let's say that your anion gap acidosis is 30. Your normal anion gap, we're going to use 10 because I like that number. That means your delta gap is 30 minus 2, or 20. And so what the delta gap should approximate is the actual change in bicarb from normal. If it doesn't, then you have a mixed metabolic acidosis. And the way the bicarb changes will tell you which one you have. So let's look at an example here. It's easiest seen through an example. Let's say these are the laboratory studies pulled on a patient. And we've got a sodium of 140, potassium of 4, chloride's 113, a little elevated. And blood gas shows 7.20, 17, 115, and 6. So your pH is 7.2, so acidotic. Your bicarbs, your PCO2 is 17. Your oxygen's 115, and your bicarb is 6. Bicarb is 6. So kind of messed up. So if you use just straight math, you calculate your anion gap, it's 21. Anion gap is 21. If you calculate the delta gap, it's 21 minus 10, which is 11. And so 11 should approximate the change in bicarb. Normal bicarb is 24. The delta gap tells us that that should have dropped by 11 points. So our bicarb should have gone from 24 down to 13. Down to 13. But our bicarb actually went down to 6. So interpreting that would make you say, well, the bicarb should have dropped for this to be a straightforward metabolic acidosis, anion gap metabolic acidosis, nothing else, my bicarb should have dropped to 13. 13. If that is true, that'd be a straight anion gap acidosis. But it didn't. It dropped down to 6. So the interpretation tells me that I lost more bicarb than I expected. I lost more bicarb than I expected. And so the loss of bicarb is what defines a non-anion gap acidosis, loss of bicarb. And so in this example, we have a mixed anion gap metabolic acidosis and a non-anion gap metabolic acidosis going on. If bicarb would have just dropped to 13, we could have quit there and said this is a pure anion gap acidosis. But since it didn't behave like we expected it to, and it went down more, then that's a mixed metabolic acidosis, both anion gap and non-anion gap. If the bicarb would have only gone down to, let's say, 17, it didn't go down to 13. That means we retained bicarb. That causes a metabolic alkalosis. Let's talk about metabolic alkalosis outside of this by itself. This is a disorder caused by addition of alkali or loss of acid. And the role of chloride, now we get back to the kidney again, if it helps determine the etiology. So there are various effects you can get from a metabolic alkalosis. It can lead to seizures, hypoventilation, etc. Okay, tissue oxygenation, ionized calcium decreases, and you can have problems with cardiac contractility. We know that metabolic alkalosis causes the oxyhemoglobin curve to shift to the left, and that can obviously cause the differences in offloading and uptaking of hemoglobin. So we define these as either chloride responsive or non-responsive. And this and that can help us determine the etiology of this metabolic alkalosis. If it's a chloride responsive metabolic alkalosis, that means the kidney's working the way it should work. Your urine chloride will be less than 20 when you provide chloride. And then we can say, well, there are specific etiologies associated with a chloride responsive metabolic alkalosis, like loss of gastric acid, volume depletion, villus adenomas, and we can look further for those types of things. The science behind the chloride responsiveness is that you have a metabolic alkalosis. So that means you have retained, right? Retained bicarb. And so that's going to drive your chloride down. Okay. And so if you provide chloride to replace that, that should drive the bicarb back down if the kidney's working right. If the kidney is not working correctly, your urine chloride is going to be high because you provide the chloride and it still allows you to excrete the chloride instead of retaining it to offset that, to drive the electric charge back in the right direction. Drive the electric charge up by adding chloride, which makes the body get rid of bicarb to solve the problem. But if the kidney's not working right, that won't happen. And so if you find that it's a chloride-resistant metabolic alkalosis, your urine chloride is high, then you can look at issues within the kidney, like mineralocorticoid excess or Cushing syndrome or renal artery stenosis as those causes. How does a contraction alkalosis, this is a term, I just like to throw this in here, explain what happens. Basically, because you would think that with volume depletion, you would become acidotic, and eventually you do. And we'll talk about this a little bit more because we're going to do renal physiology next. But volume depletion promotes metabolic alkalosis initially. So there's a loss of free water. And what that does is it concentrates your bicarb stores, giving you the appearance of a retention of bicarb. Raises your bicarb concentration also. When you do that, there's also, when you have volume depletion, you also stimulate the renin-angiotensin-aldosterone axis, and we'll look at this closer in the next lecture, which causes also a loss of acid and a loss of potassium, which makes you more alkalotic. So that's the physiology behind a contraction alkalosis. That's all. You just need to resuscitate the patient. All right. Last topic, really quick, and then we'll take a little break before we get into the next lecture. Respiratory acidosis, not going to spend a lot of time on the respiratory disorders because they're fairly straightforward, and the etiology of them is also straightforward too. Respiratory acidosis comes from retention of CO2 or ventilatory failure. If we do not have a way of clearing the CO2, then we'll become acidotic from a respiratory mechanism. There's some compensation formulas if you want to look up and see if it's a pure compensation. Respiratory acidosis with pure compensation. You can look up and see if the pH is adjusted itself. The treatment is just to treat the underlying disorder that's causing the patient to retain CO2, whatever they may be. Next, respiratory alkalosis, just the opposite. Okay, patients who become hypoxic or hypoxia can cause it because it can increase the CNS respiratory drive and cause them to blow off a lot of CO2 and make them hypocarbic, which results in the treatment itself. It's just that in treating the underlying disorder that's causing the patient to be tachypnic or hypocarbic. Okay. Quick review here. You got a 65-year-old insulin-dependent diabetic female who's brought to the ER confused, ill, and vomiting for several days. She's on no other medications or lab panels below. What is her acid-base profile? So calculate her anion gap, and if it's concerning, and then you'll need to calculate her delta gap to see if there is a mixed picture here. Give you a few minutes to work on this one. All right, let's go through this here. Don't have a lot of answers here, but we can run through this and work it out. So in this patient, if we calculate their anion gap, it's 132 minus 80 plus 16. So does this patient have an anion gap? Yeah, it's 36. It's a very high anion gap, almost unrealistic. And so if the anion gap is 36, and we say that the normal anion gap is 10, we use that. That means our delta gap is 36 minus 10, which is 26. So a little ridiculous in our numbers here, but 26. And so our normal bicarb is 24. And so that tells me that our delta gap says our bicarb should have decreased by 26. Should have gone down to minus 2. That's a little, that can't exactly occur. But what we're seeing happen is that since the bicarb should have gone down to 0 or minus 2, but it only went down to 16. So basically, we lost an excessive amount of bicarb on top of the anion gap acidosis that's going on, which would point us towards the patient having an anion gap metabolic acidosis with a concurrent metabolic alkalosis. So in other words, our bicarb should have gone down much more than 16, almost down to non-existent, but it didn't. We retained bicarb for some reason. And so we have we have a mixed entity here of anion gap metabolic acidosis and concurrent metabolic alkalosis. Okay. So that calculation there at the end is a little confusing. Just take a close look at it, and it'll all become obvious, hopefully, over time in terms of how to use the delta gap. So any quick questions before we probably take a little 5-minute break here while I swap out the slides and stuff like that? Any quick questions on fluids, electrolytes, and acid base? Patient also has a respiratory alkalosis. Not necessarily. By just looking at it, yes. But most likely what's going on with this patient is they're blowing off all this CO2 because they're excessively acidotic. They're excessively acidotic, so you can't really figure out whether the respiratory quote alkalosis is due to the fact that they're blowing off CO2 because of the fact that they're acidotic, or it's a pure respiratory alkalosis, because this is definitely not a pure respiratory alkalosis. But I agree that the patient does have the appearance of a respiratory alkalosis. So this patient is about as acidotic as I could make them with an anion gap of 36 to accentuate what the delta gap looks like. I tried not to make it so close that it would be difficult to interpret the answer. And it's most likely that this patient's CO2 would not be normal since they're so acidotic. Any other questions on this? All right, let's take a quick 5-minute break so I can get the slides swapped out so they'll show this time from the front.